Hi, Dr. Goldberg here, continuing our internal medicine lecture series. Today we're talking about irritable bowel syndrome, or IBS, otherwise known as spastic colon or spastic colitis. This is a disease entity that we see frequently in the clinic as well as in the hospital. This is a diagnosis that affects women 90% of the time. We see an alteration of bowel movements, either constipation or diarrhea or both. And then usually this is a diagnosis of exclusion, which means that a full workup needs to be done for these people who present with crampy abdominal pain. Can be in the right upper quadrant, can be in the left lower quadrant, really can be periumbilical, can be anywhere. And of course, they need not only the anatomy of their GI tract check, but also the physiology of their GI tract check. So you have to go over dietary habits in detail, as well as colonoscopy, CT scans, and appropriate testing before we make a diagnosis of, of IBS. There's no cure for IBS, and there's no inherent cause of IBS. Many different types of diets have been used for IBS, which I don't find them effective for all comers. Antispasmodic agents remain the treatment of choice, usually anticholinergic type agents, hyoscyamine or dicloclamine have some benefit at times for many people. Drugs like Amitiza or Linzess, which is for the constipation-prone IBS patients, may be very helpful. And the Linzess works through increasing cyclic GMP. We know that the GI tract or the gut does have nerves. We know that serotonin reuptake inhibitors, such as Savella, for example, and even tricyclic antidepressants have been utilized for IBS with some benefit. So it's not curable. It is controllable with the right medications, but some patients really do poorly with this disease, and will obviously see the GI consultant on a regular basis. So just a couple of pearls about IBS. Thank you, Dr. Goldberg, signing.